So, we've got emerging therapeutic options in advanced SM, looking at combination of treatment therapies. We're looking at novel KIT inhibitors. We've already spoken about the landscape and the paradigm changing in the last 10 years, making such a difference to those patients with advanced as well as indolent SM. Johannes, Andreas, and Alessandro have talked about biomarkers, molecular response guided treatment, optimizing treatments. There's all these questions about where we need to go next and what we need to think about. Before we head to that, the one or two questions from the audience I think are quite interesting to look at in terms of diagnosis. So I'm going to ask Alessandra. Peter from the audience has sent a question that says, of all prevalent advanced SM patients, how many are being diagnosed today? Percentage estimate. What do you think? That's a tough one.
Well, I think this is really a tough question, and I have no clear answer. I don't think that there are data in the literature that say...
No.
Okay. No, Alessandra, Andreas will help.
It was on one of my slides, and I missed, in the lot of text, I missed to mention that by saying that we looked at that in a limited area of Germany with about 2 to 3 million people living, where my hospital is located. And we found a prevalence at that time, but that was already 5, 7, 8 years ago, of 5 to 10 cases per 1 million people. But
that's incidence or prevalence?
Prevalence. That's prevalence. So it would mean that in my country, with 80 million, or let me say by 10 million people, you would have probably 50 to 100 patients in the country with 100 people. But the problem is really, these are only the patients who are diagnosed with advanced systemic mastocytosis. And I would guess, my gut feeling tells me that the number of missed cases may easily be at least the same number of patients again. But then you also have the problem, what is SM-AML with a few mast cells and full-blown AML? And there was really a very good analysis from a group of American pathologists who looked into their freezers, diagnosis of myeloid neoplasms, and looked only into which cases were positive for KIT D816V. And even, I think for all of us, it was very surprising that the mutation was actually found, so 50% of the cases were AML. And this is not only core binding factor AML, so we also have a disease which is totally under-recognized, which is KIT D816V positive, CBF fusion gene negative AML. And this could be de novo AML. It is probably in more patients progression of unrecognized SMA gen into SM-AML, but 50% of AML positive also for mutations in KIT, and most of them for KIT D816V. So another really, and the median survival of these patients, so we also looked into our registry, and we cooperated with 2 AML groups, large AML groups in Germany, and we found something about 40 cases with KIT positive, CBF negative AML, and the median survival of these patients was about 1 year. So KIT D816V is also a very poor prognostic mutation in whatever is diagnosed as AML. So prevalence definitely,
I think we're in a situation where I'm envious that you've got the registry and the data, because I think we don't know. I think the issue here is...
That was the point.
Yeah, I think the issue here is that we have not yet, our diagnostic criteria are much better. We have a much better understanding of, or developing a much better understanding of making the diagnosis for these patients, especially now we've got therapeutic modalities, so patients are coming out. But actually, I think international registries, the point is proven by the fantastic registry you've got in Germany in order to get that. But I think it's underdiagnosed. We don't know the numbers. I also think it's complicated because it's ISM and another hematological neoplasm, so the SM might not need to be treated. The complexity is still there, as we've outlined. But I think time will tell And it's a call out for registries and international registries in these rare diseases that will help us hopefully get some answers in the future. But Peter, a lot more cases to diagnose, I think, definitely moving forwards. Looking on to lots of questions, thank you very much. Moving on, Delia has asked a question, and it's a practical question. In clinical practice, should KIT mutation analysis be performed on bone marrow aspirate before considering mastocytosis KIT negative when the peripheral blood testing is negative? So if I've understood that, if you've got a peripheral blood negative KIT mutation, should you proceed to a bone marrow for a definitive diagnosis? Gentlemen.
If possible, in my ideal world, you should always do mutation analysis in blood and marrow. There is no other mutations which you can have such a discrepancy. So it may be negative in blood, but of course positive in marrow because the masters are in the marrow. And then you may also have discrepancies in the allele burden in blood and marrow. So it could easily be in marrow 30% allele burden because of the mast cells, and very low in blood because there are no mast cells. So it basically, the presence of KIT D816V in blood is always indicating potential multilineage involvement and potential presence of AHN. So, I mean, we are still discussing in our community, what is the threshold? I would say we do not know, but anything which is above 2-3%, you should start to think about, multilineage involvement, AHN, and then, so you also need a bone marrow biopsy to look at that. So mutation testing for this mutation, ideally always in blood and marrow.
And it's very important to really do this on sensitive assays such as digital droplet PCR or qPCR, and I think work also from the Spanish group with this rolling RCA flow assay, which is now really an ultra-sensitive technique to detect this KIT D816V mutation, might really also help us in peripheral blood to become more sensitive and to detect these cases.
You're absolutely right. The more sensitive assays we've got are going to help us twofold. One, in making the original diagnosis and getting it right, because NGS, as you alluded to, Alessandro, depending on the limit of detection, may falsely have patients identified as being KIT negative, and then they get maybe not get the right therapeutic targets. But also with the MRD following we were talking about, now that we've got these targeted drugs that work so well in terms of MRD moving forward. And I guess for advanced patients, you are going to have to look at that bone marrow because you've got the AHN. And I don't think in advanced patients you can get away with saying, we're not going to do a bone marrow. I can't see a future where you're going to say peripheral blood only, because you need to assess both components and what happens in the bone marrow. We've seen it in the trials. The peripheral blood monocytosis goes down, the eosinophilia goes down, the blood parameters normalize because of the KIT, but the bone marrow structure, architecture within the bone marrow tells maybe a different story. So I think we are always going to have to look at the bone marrow.
So never say KIT D816V negative without a bone marrow.
I think I'm in total agreement with that, because especially in the advanced patients, I think it's really important. And also, just to allude for the ISM patients, if you have a high index of suspicion and the assay is negative, the bone marrow is still the gold standard to make sure that you can, especially with the bone marrow mastocytosis. Another question from the audience, looking through. Quite a few, which is great. Let's go to Alexandra. Alexandra, there's a direct question to you, which is, for patients with SM with AML, will you use avapritinib alone or avapritinib in combination with venetoclax and HMA for treatment?
This is very difficult.
It's a very good one for you.
It's very good, but
yeah.
It's not approved. The combination is not approved, so you cannot use. There's a lot of rationale under this combination, of course, but it should be the focus of a clinical trial.
Yeah, I think again.
If I can
absolutely,
add up,
Andreas.
I mean, maybe to make the question even deeper, it is also a question: should it be concurrent treatment, if you think about, or should it be sequential treatment? And I think one really of the main problems is thrombocytopenia, caused by chemotherapy. So it may mean, you would need probably a lot of on-stop of avapritinib just to prevent, the potential risk of brain bleeding.
So I think the combination, as you said, it makes sense, doesn't it, molecularly, to look at both of these neoplasms and treat them together. As hematologists, we're used to using polypharmacy with AML, but there are the mitigating risks of intracranial bleeding, platelet counts.
Neutropenia.
Pardon?
Neutropenia.
Exactly, neutropenia, the myelosuppression.
Limit the use of the drugs, of course.
So we know that there are some patients who've been supported with GCSF or TPO to facilitate that, depending on where they are. But the combination at the moment is not licensed, to be clear. But there is a trial, bezuclastinib, APEX has a high-risk arm, and there was some work done. I guess the next question is that, have you ever tried syncopated treatment? Have you tried one and then another? So the questions, there are 2 or 3 from the audience as well, saying, how do you sequence? How do you decide between which of those neoplasms where do you target your treatment? How do you decide on following up? Which would you target first? So I'm going to just use a specific question that's been asked with would you treat the SM first or would you treat the AHN, and how do you decide? So I'm going to start off with Johannes and then just walk around to see what the panel think.
So I think this really depends on several factors. So first of all, I mean, in SM-AHN, you have already done a great job because you have diagnosed the SM compartment and the AHN compartment and have not missed one of those compartments. And then it depends on the AHN itself. Which subtype is the AHN? Is it CMML? Is this MDS MPN? Or is it more JAK2 positive MPN, which is diagnosed together with the SM compartment? And then it is also depending on the KIT D816V allele burden, in my view. Because if you have a high KIT D816V allele burden in peripheral blood, this means multilineage involvement of KIT D816V not only in the SM compartment, but also in the AHN compartment. And then you have this one marker that can be targeted by midostaurin or by avapritinib, and you can target both components with one drug. And so this really depends on several factors. While, for example, in SM, together with JAK2 positive MPN, the SM compartment is mostly of often indolent, and also the MPN is more of an indolent phenotype. And there you might not need any treatment at all, or probably the AHN compartment needs probably more treatment than the SM compartment.
So challenging, isn't it? Because we talk about markers and we talk about seeking allele burden, and not everyone has those available. Alessandro, what would be your approach with advice to a clinician who hasn't necessarily got the whole diagnostic tools in terms of initial clinical assessment?
Okay, as mentioned before, we need bone marrow biopsy. We need the determination of the KIT in both bone marrow first and peripheral blood. And again, if it's negative, it does not mean that you don't have systemic mastocytosis. And how to use for monitoring response to treatment. Well, tryptase is cheap and is quite sensitive to the effects of the drugs. But of course, it makes sense also to look at the variant allele frequency. And in that case, we use digital PCR. In our hand, it's the most sensitive of the tests. And looking again at bone marrow biopsy during treatment is important as well, especially if you also have an associated hematologic neoplasm component.
So I think that comes back to the reassessment when you've got the 2 neoplasms.
Of course, you should also measure symptoms and quantify the symptoms of the patient. This is another important objective measure of how the treatment is working.
And we saw with the trials so far with the very potent c-KIT inhibitors, patients respond quite quickly. They feel better very quickly within 2 months. The spleen shrinks, but we always have that dilemma about what's happening to the other component. Andreas, a question specifically for you. What's the specific prognosis of SM with a JAK2 mutation? Is there a difference from the other myeloid, CMML, MDS?
Well, I have to say, also working in this field of JAK2, V617F positive MPN, and I think I also mentioned it in my talk, this is really one of my also favorite topics, because the presence of this mutation may be completely different, while this SRSF2 and ZBP1, AS601, RUNX1 are really bad guys, in combination with KIT D816V, because in most of these cases, these additional mutations are in the same clone like KIT. but for the concurrent presence of CHEK2, it may be totally different. So we may really have something like CHEK2 again, or an T-like disease with very low allele burden of 2-5%, and also KIT may be very low. So we may have the situation that there is ET and indolent systemic mastocytosis. And as Johannes has just said, I mean, this is to me, at least in clinical practice, not the typical SMA-HN, although we may call it SMA-HN, but I would probably even prefer to say it is SM plus AHN, and then we may not even treat the patient at all. But it's totally different. So we may also have, and the mutations occur at different time points. So we may see, really massive myelofibrosis. I mean, we have several, I mean, you also know there are so many cases who were pre-diagnosed as myelofibrosis with a high CHEK2 allele burden. And then we may also see a high KIT allele burden. And then, of course, it is the question again, what would you treat first? And I have to say, in the meantime, we have the first patients in which we really treat with both drugs, so with ruxolitinib and with a KIT inhibitor. But I would personally always recommend to start with one, then to see, maybe sometimes only the response tells you which disease is really the dominant one. And just in general, I always think that CHEK2 is a stronger mutation than KIT D816V. So we even see some patients which have a decrease of the KIT allele burden without treatment, just on the progression of the CHEK2 mutation. So this is really a battle of the clones.
It is, and I think that's a really good way of explaining it, because we have got the kind of SM arena, the Mars, but the AHN arena is completely different with the mutations, and prognosticating that individually, because that's what we say, look at that, make that prognosis and move, but actually it's dynamic. We know that there are progression rates as you're treating patients with advanced SM, and how you balance that is quite challenging. There are loads of questions, which is absolutely fantastic. I'm not sure we're going to be able to answer all of those, but we do have a little bit more time. There is a question here about variable degrees of badness of mast cell leukemia. I think it's been addressed to Professor Reiter, but we'll throw it open. Pure MCL, we talked about that, which is just c-KIT, and then MCL with an AHN with an abnormal karyotype and circulating mast cells. So in that situation, we have a pure MCL and the one with the mutations. How would you target treatment, and do you think there is a difference in their response? Andreas, please.
Yes, I mean, in cases, what we nowadays say, pure mast cell leukemia, which means no additional somatic mutations, no evidence of AHN, KIT inhibitor, and particularly avapritinib and also bezaclastinib in clinical trials, they are really doing an excellent job in a substantial proportion of patients on monotherapy. But there are cases of mast cell leukemia, when patients really also have very bad clinical presentation. We find AHN, we find even some, very bad monocytes, whatever, pro-monocytes, whatever they are, few monoblasts. And in these cases, we may even consider intensive chemotherapy very similar to AML, or let me say AML-like chemotherapy, and then after having achieved a remission, then to continue with the KIT inhibitor. And in some patients in the middle, we may also use cladribine as monotherapy, as chemotherapy for debulking of the disease, when we really see everything is really massive, so 2-3 cycles of cladribine. But again, this is a very, very individual decision. So for mast cell leukemia, it's really between monotherapy in patients, let me say, without C findings, without additional somatic mutations, to intensive AML-like chemotherapy for patients with very advanced.
Alessandro.
If I can add, in case of pure mast cell leukemias without an important associated hematological neoplasms, KIT inhibitors may also be a good bridge to stem cell transplantation in patients who are candidates for that.
I think that's beautifully segued onto the fact that we have these amazing potent inhibitors. We find in those that are pure, and by pure just having the c-KIT mutation, but not the massively mutated landscape that we're expecting with the other additional somatic mutations, those patients do extremely well on the potent, so they would not necessarily move to transplant. I guess there are two questions I'm going to throw to the panel. One is, moving to transplant, which candidates, but how would you define optimal response before you move to transplant? So two questions. Johannes, optimal response before thinking about transplant, and is that important?
Yeah, it is. I think we tried to look into that. We looked into about 70 patients from the German registry on transplantation and cell therapy. And we looked at different response categories and how they are associated with overall survival after transplant. And we really found out that a response to either the SM or the AHN compartment, or even better to both compartments, is really associated with improved overall survival. So we should really leverage the efficacy of avapritinib and maybe in the future also other drugs to really debulk and to get a complete response in the SM, but also in clonally related diseases also from the AHN compartment, and maybe even if the SM compartment is already in complete response, to really sequence with, I don't know, HMAs to really also get a response or better response in the AHN compartment, if this was not already the case. So I think it does matter that a patient has a response before a transplant, because the data on overall survival, progression-free survival was really way worse than those patients who did not respond.
So try and get that SM component as low as possible. Optimal will depend on patient. Where do transplants sit in your paradigm now when you're seeing patients in your clinical practice, Jens? Andreas.
Well, I have to say, I mean, again, also, talking for a second also about myelofibrosis, I mean, there we also talk about transplant all the time, but at the end of the day, only 10 to 15% of patients are transplanted, even in the big centers. I mean, all these diseases are diseases of older age. So, and of course, I mean, we collected, I think, something like 70 patients transplanted for mastocytosis in the last, 10, 15 years in Germany. I mean, it's still, to get a patient with advanced systemic mastocytosis to transplant, I mean, this is really a tough job. And I think that if there's any if there are transplanters in the room who have already transplanted a patient with mastocytosis, I think many transplanters do not that much like to transplant myelofibrosis, and even less mastocytosis. I mean, even for transplant, and also the management after transplant. This is also not really easy. I mean, I personally would also always recommend that the KIT inhibitors, whichever, should also be part of the treatment of the patient prior to transplant and also post-transplant on whatever basis, mutation testing. But overall, I mean, although we are a very big center, we have seen many, many patients. I mean, we have probably also only transplanted something like 8 to 10 patients in the last years. I mean, very tricky job. But you have to think about it. You have to consider it. Keep it in mind, And of course, it also depends on donor, everything. But at the end of the day, we have patients which we consider to have cured, with this approach of KIT inhibition, transplant, plus minus KIT inhibition after transplant.
Alessandro, where would you place that?
I agree. I think that there is the opportunity of a stem cell transplant, which, as alluded by Andreas, is quite rare, because these are most advanced age patients. One should pursue stem cell transplantation, and any kind of response that means not full resistance disease is okay if you can bridge the patient to stem cell transplantation. And a few patients are indeed cured with stem cell transplantation. Yeah. They are very rare, but they do exist.
So I think having the new targeted therapies has meant that we can reduce the SM disease bulk to a much better place than we've seen before, and transplant still is a curative option. But again, like with all of our patients with advanced SM, it's going to have to be individualized for that patient, especially with the seesaw with the age.